Hello and welcome. You are watching Step Up Medicine's video on VQ ratios. Oxygen gets into your lungs. Blood flows through your lungs. But how well they match determines how efficiently you exchange gases. In this episode, you'll learn what ventilation-perfusion ratio means, why it varies from top to bottom in the lungs, what happens when there's a mismatch, and how conditions like pulmonary embolism, COPD, and shunting affect gas exchange.
V/Q, or ventilation-perfusion ratio, compares two things. V is ventilation, how much air reaches the alveoli. Q is perfusion, how much blood reaches the alveoli via capillaries. For efficient gas exchange, these should be well matched. The ideal V/Q ratio is about 0.8. That means ventilation and perfusion are roughly balanced, but not perfectly equal. The VQ ratio isn't the same throughout the lungs. Gravity affects both air and blood distribution. At the apex, or top of the lung, ventilation is low, perfusion is even lower, so VQ ratio is high, sometimes greater than 1. At the base, or bottom of the lung, both ventilation and perfusion increase, but perfusion increases more, so VQ ratio is lower, often less than 0.6. Despite this variation, the lungs still manage efficient overall exchange. When ventilation and perfusion don't match, gas exchange becomes inefficient. This is called VQ mismatch. Let's look at two extremes. First, dead space. This is when ventilation is present, but perfusion is absent. Air gets in, but there's no blood to pick up oxygen. A classic example is pulmonary embolism, where a clot blocks blood flow to part of the lung. Second, shunt. This is when perfusion is fine, but ventilation is absent. Blood flows through the lung, but doesn't get oxygenated. This happens in atelectasis or fluid-filled alveoli, like in pneumonia. Both scenarios reduce oxygenation, but only shunt won't improve with extra oxygen. Let's apply this to real-world conditions. Schuppersons, Didigolar, pulmonary embolism. Blood flow is blocked. Didigolar, ventilation remains, but perfusion is lost. V/Q goes toward infinity. This is dead space. COPD and asthma. Airflow is limited. Ventilation decreases, but perfusion continues. V/Q ratio drops. This causes hypoxemia, pneumonia, pulmonary edema, or ARDS. Fluid in the alveoli prevents ventilation. Perfusion is still there. V/Q ratio approaches 0. A shunt effect. Right to left cardiac shunts. These bypass the lungs entirely. Blood never sees alveolar oxygen, leading to severe hypoxemia that does not correct with 100% oxygen. Your lungs try to fix V/Q mismatch automatically. If an alveolus is poorly ventilated, the body reduces blood flow to that area. This is called hypoxic pulmonary vasoconstriction. It helps redirect blood to better ventilated alveoli. Buckerman. It's a smart way to minimize mismatch. Buckermala. But if it happens across large areas, like in high altitude or widespread disease, it can increase pulmonary vascular resistance and lead to pulmonary hypertension.
Let's summarize the key points. The Q ratio compares ventilation to perfusion. An ideal ratio is around 0.8. The apex of the lung has a high VQ. The base of the lung has a low VQ. Mismatch leads to inefficient gas exchange. Dead space is ventilated but not perfused, like in pulmonary embolism. Shunt is perfused but not ventilated, like in pneumonia. Here is a quick question to test your knowledge. In a healthy upright person, where is the VQ ratio highest? A. Base of the lung. B. Apex of the lung. C. Middle of the lung. D. Equal throughout the lung. Drop your answers in the comments. If this helped clarify your basics, like and subscribe for more high-yield videos. Thanks for watching, and keep stepping up your knowledge.